Hello, everyone. It's Dr. Marianne McLaughlin, and it's my pleasure today to talk about the topic of hypertension in older adults. I have nothing to disclose. Today, we're going to start talking about hypertension definitions because these tend to change every few years with new recommendations coming out. We're going to look at the pathophysiology of hypertension so we're all on the same page of what's really going on internally. We're going to define appropriate blood pressure targets based on patients' demographics, age, other comorbidities, etc. And then importantly, we'll talk about treatment. First, an uncomplicated hypertension, secondary hypertension, patients who have coronary artery disease, or patients who have resistant hypertension. Importantly, the American College of Cardiology, American Heart Association have come together to give definitions of what is appropriate. And the definition of hypertension, it can be described as normal blood pressure, elevated blood pressure, stage 1 or stage 2 hypertension. And we look at what the categories are in our practices. So normal blood pressure is considered less than 120 systolic and less than 80 diastolic. Elevated blood pressure is considered between 120 and 129 and over 80 diastolic. So when we talk about what is hypertension, we talk about different stages. And the first stage, stage 1 hypertension, is a blood pressure systolic of 130 to 139 or a diastolic of 80 to 89. Stage 2 hypertension, where the risks of cardiovascular and neurologic events occur, is really stage 2 when the blood pressure is greater than 140 systolic or 90 diastolic. As we age, there can be other changes of blood pressure. The first one is systolic hypertension with a low diastolic blood pressure or wide pulse pressure, which sometimes is a little more tricky to treat because when you lower that upper number, then the bottom number is going to go down with it. And that can cause people to feel funny or faint. Then we have what's called a loss of a dipping pattern. So when we sleep, our blood pressure is supposed to dip. We're supposed to be resting, and so the blood pressure is supposed to be lower. And in some people, as we age, their arteries get stiff and they don't have that dip in blood pressure, which is normal. Orthostatic hypotension is if going from a seated position to a standing position, there's a drop of more than 20 millimeters of mercury. So that's considered abnormal. It's orthostatic hypotension. It can lead to people having fainting. What's very important to know is that if you have an older population who are tending to have more orthostatic hypotension, you have to treat to that standing blood pressure. Otherwise, they're going to faint. So if you have a blood pressure of 140 over 90 seated, but you stand up, then blood pressure goes to 110 over 60, we have to treat to that number so that we don't drop that blood pressure so patients don't faint. And finally, a very important thing to know about is postprandial hypotension. I've had families come to me and say, I don't know what it is. Every time my mother goes out to dinner, she looks like she's about to pass out. Well, that's what's happening, is she's eating a large meal and the blood pressure drops. And the term is a term called postprandial hypotension. So it's another important thing to know about in your clinical world of things to watch for. This is just a pictograph of what looks like as the population ages. And we have men in the blue and women in the red lines. So starting, let's say this is in the teens, 30-year-olds, 40-year-olds, blood pressures are usually, in the 110s. But if you see after you cross the age of 50 to 60, the systolic blood pressure just keeps going up. It cups up to 130s, 150s. There's your hypertension. And what's happening to the diastolic blood pressure? It stays low. And this is that gap in blood pressure. So we mentioned briefly dipping. So importantly, when we sleep, our blood pressure doesn't need to be so high. we don't need it for activities, for walking, for exerting ourselves. So the blood pressure usually drops. It's called dipping during sleep. And so on this pictograph, you can see a normal blood pressure. And then later, the blood pressure goes down during sleep and then goes back up again. And that's normal. But there are other possibilities. Some people have what's called an extreme dipping, where their blood pressure goes really too low during the nighttime, and then it persists, which gives them an increased risk of having untoward events such as fainting or falls. Then there's a non-dipper, and then there's a riser where the blood pressure actually goes up higher than it should at sleep. Importantly, as patients get older and they discuss different side effects or different symptoms at night, it's worth doing a 24-hour blood pressure monitor that can actually diagnose these dippings and see whether we're giving them too much blood pressure medication in the late afternoon that's exacerbating the dipping and making them have symptoms such as falling. So that's an important thing to remember, 24-hour blood pressure monitor. And this is just an overall review of this age and prevalence of orthostatic hypotension. Orthostatic hypotension, again, is defined as when you stand up and the systolic blood pressure drops 20 millimeters of mercury or 20 points. And so starting around age 60, there's some, we can see that in our population. Between 65 and 70, it really around 20% of the population will have that. It's very important in your office that you make sure you check that standing so you don't over-treat so people don't faint. So we started to talk about stiffening of the arteries. Well, what really happens pathophysiologically is that the elastin levels are lower and there's an increase in collagen and calcium deposition in the arterial media. So what that happens, we start to see that the systolic hypertension in the elderly. So the blood pressure is high in the top number and the systolic number, but it's low or normal in the diastolic. So again, that can be associated with an increased risk of heart attack, left ventricular hypertrophy, kidney dysfunction, stroke, and cardiovascular death. So those patients who have this isolated systolic hypertension can be very tricky. Also, two more things that happen as we age. There's something called a flow-mediated arterial dilatation, which is helpful when we need to dilate our blood vessels and get more oxygen to different muscles. But that is usually declines with aging. So the response to exercise also can be lower in an older person. And finally, pathophysiologically, the neurohormonal profile as we age is characterized by increased norepinephrine and low renin and low aldosterone levels, which, as we know, are implicated in blood pressure. So this is a big slide, a big summary of what happens during aging. So the arterial systolic blood pressure goes up and the diastolic goes down. That's what we just mentioned. Myocardial ischemia is increased risk as we get older. Increased left ventricular wall thickness, increased left atrial size, which can lead to arrhythmias. So all of these things that are coming from changes in blood pressure can have effects on other physiologic processes in the heart, leading to possible fainting and leading to possible arrhythmias. Also, the aortic size, the root can get larger, which can lead to increased risk of tears or dissection. So if we don't treat blood pressure and that blood pressure keeps going up with age, we have this increase in arterial stiffening, and that can lead to these other events that you need to know about. So what's the target blood pressure, right? Every few years, there's a new guideline that comes out, right? So where we are now is that what to do with a blood pressure who's had a patient who's had hypertension and they've had a cardiovascular disease event, such as unstable angina or heart attack, or when we use this calculator called the ASCVD risk calculator, if they have many risk factors that lead to a 10% or higher, then we really need to keep their blood pressure less than 130/80 to lower their risk of heart attack. And then this is a goal for patients with confirmed hypertension. Even if they don't have risk factors for cardiovascular risk, it would be reasonable for them also to have a blood pressure in that range of 130/80. Unless people who have many comorbidities, a limited life expectancy, um, and their patient preference is not to be strict with their blood pressure, then there is a class of medications of patients that we don't have to be so strict with the guidelines. So what is the diagnosis? What is the goal? So isolated systolic hypertension. Remember that coronary artery disease risk varies directly with that high systolic blood pressure. And we have worse outcomes in people who are older and have a low diastolic pressure. So this is where we have to be very thoughtful about the medications we give. The goal should be a diastolic blood pressure over 65 in patients who have coronary disease. Because if you decrease their diastolic blood pressure, the perfusion of the coronary arteries is going to be less, and they may be at risk for more angina or heart attacks. It's important. So we should talk about this. How do we measure blood pressure? All right, so it's important in the office that we do it well and that we teach our patients how to do it at home. First, we prepare the patient using the proper technique. We want the patient to be seated with their arm at the level of the heart on a table. We're going to document the readings, and I recommend taking at least 2 readings in each visit, sometimes a third if the first 2 readings are far apart from each other. And then we average those readings and we provide those readings to the patient to take home and to follow the same routine when they're at home. At least 2 blood pressures in a seated position with the arm extended. And so this is a pictograph from the American Heart Association. Again, we recommend that patients with hypertension do learn how to measure their blood pressures at home and obtain a blood pressure monitor. The one thing we can do as a physician for them, we can have them wear a 24-hour ambulatory blood pressure monitor to check the blood pressure throughout the day and evening, to really be able to accurately know if we're over-treating or under-treating someone. So the patient should be checking their blood pressure 30 minutes beforehand without smoking, exercise, caffeine, or alcohol. Make sure you do that when you tell the patients at home to avoid those things. And at least 5 minutes wait seated before you check the blood pressure. And again, right before you do it, you make sure the cuff is fitting nicely and it's not too tight. And then you write down the blood pressure and you wait a few minutes before you check it a second time and keep a log. This is what you're going to teach your patients. And then this is a nice large example of what normal and blood pressure is and what to do. So normal blood pressure, less than 120/80 in a seated position. You continue to promote optimal lifestyle habits, which is good amount of exercise, a diet that's low in saturated fats and salt, and getting adequate sleep. Importantly, to be checked for obstructive sleep apnea if someone has sleep as the hypertension and no other risk factors. Elevated blood pressure is considered 120 to 129 over 80. Stage 1 again is between 130 and 139 over 80 to 89. And stage 2 is greater than 140 over 90. And again, we're going to treat accordingly to reduce our goal. Remember, is to reduce our risk of cardiovascular events and stroke. So the first case we have to talk about is a 72-year-old woman who comes for a pre-procedure for colonoscopy. So she needs quote unquote clearance for colonoscopy, but in the office, her blood pressure is 160 over 88. And so she's told to go home, to avoid salt, to get adequate sleep. She comes back, her blood pressure is 158 over 82. And she said, "Oh, this is normal for me. I always get this high blood pressure in the office. It's just white coat hypertension." She always refused medication. So on exam, we're doing a physical exam. She has no carotid bruits. Her cardiac exam is normal, normal S1, S2, no murmurs. Abdomen has no bruit. So we're listening to see if we have any vascular disorders that can be raising her blood pressure. We check her pulses and they're intact throughout. So what should we do? That's where we talk about doing out of office. So in the office, her blood pressure is elevated on 2 readings. So now we say, let's do some self-monitoring at home. And so the patient is instructed on how to obtain a blood pressure machine and check herself. Or we can do that 24-hour blood pressure machine if the patient is not able to check their blood pressures themselves. And so then we have these patterns. So if they have normal blood pressure in the office and at home, then they don't have hypertension. If they have sustained hypertension in both the office and the home, then they have hypertension diagnosis. Now, a masked hypertension diagnosis is if in the office the blood pressure is quite good, but at home it's elevated. So that's the opposite of what we anticipate. We see more likely white coat hypertension when patients come in, their blood pressure is elevated to 140, 150, and they say, "Oh, I never ever get this at home." And then, in fact, we make them do their blood pressures at home, and they're right. So this is a white coat hypertension. So we don't want to overtreat that the patient with white coat hypertension and give them too many blood pressure medications or too strong of a medication dose, because then at home they'll feel like fainting or they're faint. So again, this is from the American College of Cardiology, just a decision tree of what do we say if we can't figure out the difference between home and office, then we do the ambulatory blood pressure monitor, right? Or the home blood pressure monitor. And we use those numbers to inform the patient and to choose the appropriate therapy. So when a patient comes in for an ambulatory home blood pressure monitor, and they get it placed on in the office, and then they wear it for 24 hours, and they keep a log of their symptoms, and we get this great picture of what the blood pressure is like systolically and diastolically for that whole time. And we can see when there's peaks and valleys, and we can see if there's an association with heart rate. So the heart rate also can go up during the day and then decrease. So if we look at the clinic blood pressure is a 120 over 80, and the home blood pressure monitor is 120 over 80 in the daytime, and then the nighttime drops down to 100. And then we see, well, what goes on in the 24-hour ambulatory blood pressure monitor? It's not so bad. So it's around the average. So at nighttime, it dips, which is normal. So the average is still quite low. And on the other extreme, for the patient who has a blood pressure of 160 over 100, and then they wear a 24-hour ambulatory blood pressure monitor, it's 145 over 90. We want to treat to that 145 over 90 because this looks like it's erroneous compared to all the other. So if we overtreat with medications, the patient might feel dizzy or faint. So in order to provide our patients with optimal treatment, we want to talk about not just pharmacologic treatments, but we want to talk about other non-pharmacologic interventions to prevent and or treat hypertension. And these have been studied and are part of several guidelines to start with weight loss in someone who has excess body fat. If you can see a reduction in blood pressure of 5 millimeters of mercury in those who are hypertensive. So we aim for at least a 1 kilogram reduction in body weight for most adults who are overweight. And there's an association of, as you lose, for every 1 kilogram of weight loss, you can drop 1 millimeter of mercury of your blood pressure number. So that's important. Number two, the DASH diet. So the DASH diet was the largest dietary intervention for reducing blood pressure and showed that those who assumed that diet actually had a marked reduction in blood pressure. So that DASH diet is now available online with where you can have menus and give you interesting options. It's a diet that's high in fruits and vegetables and whole grains, low-fat dairy products with reduced saturated and total fat. So it's a very heart-healthy diet now. And the blood pressure, top number, systolic blood pressure, can go as low as 11 points lower. So this is how some people with borderline high blood pressure can do well without taking medications if they follow a healthy lifestyle. Reducing dietary sodium. The goal should be less than 1,000 milligrams per day. So look at the labels of all the foods you're buying, especially if you're buying dinners that are frozen dinners or prepackaged dinners. They might have more salt than what you would do if you were cooking at home. But you want to be able to lower that blood pressure back to a normal. And then potassium. So having a healthy diet of potassium may actually help keep your blood pressure in a better control. Exercise, aerobic exercise. We say that if you can get your heart rate up and stay fit with aerobic exercise, you can keep the artery and the integrity of the artery walls healthy. So you would want to try 90 to 150 minutes of exercise per week. And with that, you can lower your blood pressure 5 points on the top number and 8 points on the diastolic reading. That's very important. Resistance exercise. If those of you cannot do some aerobic exercise, but you do resistance exercises, again, you can lower that blood pressure by 4 millimeters of mercury. If isometric exercise has been proven to lower blood pressure, 5 millimeters of mercury. And this is also important, alcohol consumption, right? So in individuals who drink alcohol, for women, they say less than or equal to 1 drink a day. Lowering can lower your blood pressure 4 millimeters of mercury. And for men, if they can keep their alcohol consumption less or equal to 2 drinks per day, they can also lower their blood pressure if they have hypertension. And even if they are someone with normal blood pressure, they can be even healthier numbers with reducing alcohol. A sodium restriction. We say if someone is really watching what they're cooking with, you want less than 2 grams or 1 teaspoon of salt to be taken in each day. And the trial, which is several years ago, that showed that those people who actually were randomized to a salt reduction diet and were followed for over a year or 15 to 36 months, they dropped their blood pressure 2 to 4 points in the top number. And I've seen that in my office, and patients have done a very good job of changing. So case number 2. So now we have a 69-year-old gentleman with a long-standing history of gastroesophageal reflux, benign prostatic hypertrophy, and obesity. He had no history of high blood pressure, but he has not been seen by a physician in a year. He's taking omeprazole and aspirin. He has not been taking the things that we look for when we see someone with a new blood pressure spike. He's not taking non-steroidal anti-inflammatory medicines, steroids, decongestants, some antidepressants, and some amphetamine, like drugs for ADD, that can all increase your blood pressure. This gentleman is married. He drinks 1 beer a day, he says, and does not smoke. On exam, his BMI is a little bit higher than normal, 34. His blood pressure is 180 over 112 bilaterally. His eye exam is normal. Cardiac exam has normal heart sounds without a murmur, Robert Gallup. But importantly, this is what we have to do, check for abdominal bruits. You want to see if the aorta is intact, and you want to feel the pulses, right? So this gentleman had a decreased pulse in the right leg. So that you think about this, and this is actually a true patient. So we talk about looking for renal vascular disease. Does he have an aneurysm, or does he have a narrowing in his right low extremity? Does he have peripheral vascular disease, which is often coexistent with hypertension? The other reasons that we can think about that can be treatable to actually lower blood pressure is primary aldosteronism. And so the latest guidelines from 2025 from the American Heart Association says if a patient comes in and they have systolic hypertension with no other etiology, you should really check their aldosterone levels and check for primary aldosteronism as a cause for hypertension. Obstructive sleep apnea is something we ask for every day in our office because it's such a prevalent disorder. Many people snore. They are tired during the daytime, but they've never been tested. But if they're coming in with hypertension, that's a perfect reason to suggest that they be tested and treated for their obstructive sleep apnea. Again, we said more than one drink for a woman, more than 2 drinks for a man can increase their risk of hypertension. Medications such as NSAIDs, cocaine, amphetamines, steroids, all of these can increase your blood pressure. And 2 other metabolic endocrinology syndromes, the Cushing syndrome and pheochromocytoma, are things that if everything else has been ruled out, is to consider evaluating for. So again, the summary of screening for secondary hypertension, if you have a patient who has new onset of hypertension at age 50 without any changes in lifestyle or anything, or an uncontrolled hypertension patient coming in, these are the things to keep looking at and screening for these secondary causes. So the secondary causes would be kidney disease. So you look at their creatinine, renal vascular disease. So you're looking at renal artery stenosis. Very important. Can be seen with aortic disease as well. Then again, primary aldosteronism, sleep apnea. This is a good review, and drug or alcohol induced. Pheochromocytoma or paragangliomas are more uncommon, but we do see them in our practice every few years. The other things that we see in the Cushing syndrome, thyroid disorders, either hypo or hyperthyroid, aortic coarctation. So think about that in someone who has differences in pulses, hyperparathyroidism, congenital adrenal hyperplasia, acromegaly. We've seen every one of these in our offices. So these things to think about as causes that you can treat and get the blood pressure controlled. So for renal artery stenosis, in the past, we used to do medical therapy, but now the cure can be actually stenting of the renal arteries, or renal artery angioplasty and or stent placement. We look for renal artery stenosis in a patient who has 3 things. Either their blood pressure was refractory to treatment, so they were treated with different medications and the blood pressure never went down. Their creatinine or renal function declined, or they developed congestive heart failure. You have to think about renal artery stenosis and vascular disease. Again, screening for primary aldosteronism would be something to do if there's hypokalemia or incidentally, there's an adrenal mass, or a family history of very early onset hypertension or stroke in someone less than 40 years old in that family. You have to think of aldosteronism. And then we can do screening with the blood tests and then refer to a hypertension specialist and or an endocrinologist for appropriate treatment. And then sleep apnea treatment, we talk about CPAP. And sometimes it's weight loss depending on the patient's size, whether weight loss would treat sleep apnea alone or whether CPAP is necessary. Case number 3, a 74-year-old with a history of dyslipidemia and GERD comes for follow-up. He can walk 1 mile without any symptoms. He's no chest pressure. He has a blood pressure of 160/80. He has no carotid bruits. His lungs are clear. His cardiac exam is normal. His abdomen is soft, non-tender. He has decreased pedal pulses on the right leg. And so the physician importantly asked for an ankle brachial index, was performed and found to show that the right lower extremity perfusion is diminished compared to the left. So what would you suggest we do? Should we treat for hypertension and evaluate with the MR angiogram of the lower extremities? Should we treat and include aggressive multiple risk factor interventions and antihypertensive drugs? If the resting EKG is normal, no further interventions are doing, they say do nothing. Or should he have an exercise stress test to look for coronary disease? So he should be treated, right, with aggressive treatment. And his goal should be less than 130/80. And how do we get there? So when patients have coronary disease or vascular disease or angina, what we say, we can add medications like beta blockers, carvedilol, metoprolol, nadolol, bisoprolol, propranolol, and timolol. Excellent beta blockers for GDMT treatment of blood pressure in patients with vascular disease. Let's see. We can add calcium channel blockers, such as dihydropyridine calcium channel blockers, or which would be like an example would be amlodipine. We can add diazide diuretics if they don't have angina. So again, stable coronary disease, stable ischemic heart disease, you want the blood pressure less than 130/80. You can do with medications, and you can add secondary drugs. Okay. Case number 4 is a patient is an 81-year-old with a blood pressure of 168/94. She has no diabetes, she has no chest pain, no shortness of breath. Our physical exam did not reveal any noticeable cardiovascular disease, no valvular disease on exam. She has bloods done, CBC, metabolic panel, lipid panel, urinalysis, EKG were all normal. So what would you suggest to treat her with? So she's 168/94 on repeated measures without diabetes, right? So should you do a beta blocker, atenolol with a diuretic? Would you do lisinopril, ACE inhibitor with a diuretic? Or lisinopril plus an angiotensin, a calcium channel blocker? So let's see. So importantly, with this patient, an initial trial of an ACE inhibitor or ARB with a diuretic or calcium channel blocker would be appropriate to keep her blood pressure in a good range and also help protect her kidneys. So atenolol had been studied in several studies and found, compared to other choices, the results were with the beta blocker was worse. That was using atenolol. So subsequently, the ASCOT study looked at the amlodipine-based versus atenolol-based, and again found that amlodipine-based in general had better outcomes. And this is also a study looking at central aortic blood pressure, seemed to be lower with the amlodipine-based blood pressure. And why do we use chlorthalidone as a diuretic? So there was a very impressive study called the All Hat trial, and it looked at major outcomes, including mortality, coronary heart disease, stroke, or generalized cardiovascular disease as the outcomes, and found comparing angiotensin inhibitors that ACE inhibitors and ARBs are excellent choices, and chlorthalidone was effective as a diuretic. So the chlorthalidone is going to be better than the hydrochlorothiazide. The other diuretics used for heart failure, furosemide is used with congestive heart failure with class 3 or 4, or a CKD with a very low eGFR. Then furosemide can be used also in addition to other to the ACE or ARBs. So when we talk about combining medications, we always say start low, go slow. We don't want to drop them too fast. Most people in their 80s do not want diuretics because they don't like the side effects. Usually beta blockers are not the first line treatment, but they are in certain cases. They're definitely first line for patients with coronary artery disease or patients with arrhythmias. So don't forget that. Consider cost when you're talking to the patients. Case 5, 75-year-old male with no past medical history. He is diagnosed with hypertension and in urgent care after an injury. He lives alone. He doesn't have any symptoms of chest pain, shortness of breath, dizziness. On exam, though, his blood pressure is 174 over 104. He has no carotid bruits or murmurs. He has some edema, some trace pedal edema. His EKG is normal. His GFR is a little low with a urine albumin creatinine ratio, which is elevated. So what do we want to do for him with hypertension, renal disease? What should we give him? An ARB or an ACE with a loop diuretic, a chlorthalidone based, or a beta blocker chlorthalidone? And the answer is ideally you want to do an ARB or an ACE inhibitor. So that will give you long-term benefits, cardiovascular benefits, and chlorthalidone as the diuretic. And what should his target blood pressure be? 150, 140, 130, 120, 130 over 80. And that we can see the recommendation for treatment of hypertension in patients with CKD. So adults with hypertension and renal disorders should have a goal of less than 130 over 80. Resistant hypertension is a diagnosis that's made as a diagnosis of exclusion. So you have to figure out what could it be first. So you do, is it white coat hypertension? And the way to test for white coat hypertension or blood pressure that just goes up in the office is a 24-hour ambulatory blood pressure monitor to really see if it's normotensive at home. Then we look at medication effects. We tell patients to stop their NSAIDs, their decongestants, their stimulants, and see if that makes the blood pressure return to normal. Secondary forms of high blood pressure would be renal artery stenosis, so that's a vascular problem, thyroid disease, hyper or hypothyroidism can be associated with hypertension. And then the other primary aldosteronism or endocrine abnormalities, or pheochromocytoma, where there's an increase in adrenaline circulation. So those are all very important things to evaluate if you're trying to find the cause of someone who has resistant hypertension. So first you titrate their usual blood pressure medications. And then you can add, if they've done that, then you can add either a spironolactone, which is an MRA, a hydralazine, or an alpha blocker. So that's a good thing to know after you've tried the first line therapies. And this was a study many years ago, but it showed that with resistant hypertension, in 3 months of treatment of these medications, adding spironolactone with doxazosin, bisoprolol, actually lowered blood pressure. So what are the pitfalls? Pitfalls of pharmacologic therapy, right? So the drugs, all drugs can be affected if there's a reduced gastric acid production. The tablets aren't dissolved easily, and so then they might not be getting into the bloodstream effectively, and they might not be, effective. Second is patients who have a reduced gastric emptying time. That also will lead to decreased absorption for the acidic-based drugs. And if there's a GI motility, it's important when you're taking your history, you find out about any GI motility disorders, and realize that that can cause less absorption of the drug. Overall body mass and body fat, especially can affect beta blockers and central alpha agonists. If there's if people are dehydrated, the volume of distribution can definitely affect the effectiveness of ACE inhibitors to be over effective. And then those who have low albumin level states, so the drugs like propranolol, the distribution can be abnormal. So metabolism and excretion of medications can affect pretty much all of the drugs that we use. So propranolol, diltiazem, labetalol, verapamil, ACE inhibitors, all of those can be affected one way or another, depending on reduced GI performance and reduced kidney function. So 10 things you need to know. There's been a dramatic increase in hypertension prevalence with aging. And so by 70 years of age, the majority of people will have hypertension. So it's important that people get checked from the doctor's office, but learn how to do home blood pressure monitoring. It's a very significant risk factor for heart disease, angina, heart attack, and stroke in the elderly. There have been several trials that have shown a reduction in those bad outcomes, heart attack and stroke, in patients 60 to 79 years old, using blood pressure medication therapy. And finally, although the improvement in blood pressure control has really occurred over the last 20 years, importantly, blood pressure control rates remain suboptimal in the older patients. So the non-pharmacologic methods should be treated first, right? Should be used first. And then, although in the elderly, a threshold of 140/90 is reasonable to really treat with blood pressure medications and not just with modifications in lifestyle. So all of the different classes of medications have shown benefit on cardiovascular endpoints. So ACE inhibitors, angiotensin receptor blockers, calcium antagonists, beta blockers, and finally adding on a diuretic has been helpful. So what you want to do in the older patient, in the hypertension in the elderly, you need to start with the lowest dose and increase gradually. And then because of the increased risk of comorbidities in our older patients, we need to really look to avoid treatment-related side effects. So thank you very much for your attendance today, and to Mary Ann McLaughlin, Mount Sinai School of Medicine, if you have any questions. Thank you very much.